is one of our graduates out of our second year cohort. And as you heard, she's up in the Jackson Victor Driggs area. And Makeesa, love to see your face. So I think, well, Ivan and Lisa know each other. They practically grew up together in the world of OT, going to school together. So I think everybody else pretty well knows each other, because Ivan, you and Anna know each other from our TAC committee, and Anna graduated from the MOT program a little bit after you guys, I believe.
Yep, I know we've met a couple of times, but
yeah,
my camera's not working.
That's okay. So we will take this time. Thank you so much, Makeesa and Ivan, for being willing to do this May Journal Club and sharing your expertise in the area of pediatric incontinence. And we'll turn it over to you.
Okay. So I guess a disclaimer that this is not an area that I ever thought that I would be working in. I just started a new student this morning from St. Augustine down in San Diego. And I was telling them, of course, we're having the initial discussion about, well, how did you get into OT and the swapping stories back and forth. And I said, you know, on my journey into discovering what OT was and deciding to go into OT, I had thought about psychology, I thought about speech therapy, but I had decidedly said no to physical therapy because I didn't want to get my hands on people that much. I was too hands-on. And so here I am doing pediatric incontinence, and my hands are all over places that my physical therapist will still shy away from. So it's just kind of ironic. Back in 2014, there was a lot of patients and families who were talking about struggles that they were having related to incontinence, bowel and bladder and pelvic floor function. There just wasn't a really good option for anybody in the Twin Falls area. And so finally I said, you know what, I'm hearing that there's a need. I'm seeing that there's a need. And so patients had actually had to have some pretty significant surgeries because there wasn't the therapy available. And so I said, enough is enough. I'm going to step up into something that I'm initially uncomfortable with, and I'm going to get some training, and I'm going to make a difference. And so for the last 8 years, I've been, in addition to all the other stuff that I do, I've been doing pediatric incontinence, and it has been absolutely fantastic and very rewarding to see the difference that even just small things can make. Even just simple education and teaching people about their bodies and how the digestive system works and how that influences bowel and bladder function. And it truly makes a huge impact on so many other people. But to begin with, to really dive into the discussion, I thought, well, here I am. I'm speaking to a bunch of peers and who have understanding of occupational therapy and of the body, but I still kind of want to take it back to the basics and just review and get everybody on the same page as far as, well, what are we talking about when we are talking about the pelvic floor? And so this is actually really similar to how I begin to educate some of my parents and clients. So feel free to steal these highly descriptive drawings that I'm about to do, if I can do this backwards. So can everybody see that? It looks good on my screen. Okay. This is the human body. Just highly descriptive. Okay, so then I draw this giant mouth and I show some teeth in it. And I say, okay, so what are you guys eating? And they come up with all sorts of stuff. What I'm looking for is, you know, this is an education piece, but it's also a screener to see, well, what are these people actually putting in their bodies? Because a lot of the times they won't even mention water. And so we have to educate on the importance of water. Pizza is a really common one. And pardon the peacocks that you can hear behind me. It's mating season, so they're loud and obnoxious. But all this food goes in the mouth, of course, and it travels down the throat into the stomach. which is broken down into little parts. And then it goes into the small intestine, which I could tell the kids that these are your squiggles. And we have all sorts of stuff happen in the small intestine. We have nutrients, we have proteins, all that stuff gets given to the body. And then this is highly simplified, of course, but we go into the colon. And really, I mean, I think the lay understanding of the colon is that, oh, okay, well, this is where stool comes from. This is how we make our poop. Okay. And that's not, I mean, that's what happens, but the colon is very, very complex, and it does a whole bunch of functions. But one of the key functions that we consider is that it is what draws water back out from when we drink it and then gives it to the body so that we can stay hydrated. This water then, of course, goes all over the body. It's in the blood. It gets filtered by the kidneys. The kidneys filter in the bladder, and then the bladder is where it stays until we excrete it or we void it into the toilet. Meanwhile, all of this loose stuff that our body doesn't want, the waste, it slowly comes down here as water is extracted from it, and it forms into what we know as stool, and then it's excreted by the body. And here's our legs, okay? And so then we consider, okay, so what is going on when there are challenges in bowel and bladder function? All my classes I've taken through, it's a company called Herman and Wallace. They are the big company that takes care of pelvic floor, continuing education. Dawn Sandalcini is the one that I've taken most of my classes from, and she is fantastic. She's based in Denver. But her saying that always kind of makes me chuckle is, you are constipated until proven innocent. Meaning that, you know, we don't know a lot of what is going on inside our own bodies or our clients' bodies until we can prove that it's not happening. And estimated 80% from studies that they've done, 80% of times when you have children, and I've focused my practice on pediatrics, pre-adolescence, I'll do education after that, but a lot of the techniques for post-adolescence are very different. 80% of the time when there is bladder incontinence is because of constipation. There's a direct link, and there's a direct link to a lot of other things going on as well. But if we consider that right where the colon comes down into the pelvic floor, the bladder sits right next to it. And if we have constipation going on inside the colon, it's creating a lot of hardness and pressure against the detrusor muscle around the bladder that is soft and it's balloon-like. And so then you have this pressure that then crushes into the bladder, creating, the bladder can't expand the way that it's supposed to, and sensation is lost because of that constant pressure that's placed on it. Both the bladder and the rectum at the end of the colon, their neuroreceptors are to give our sense of urgency is based on stretch and pressure from the inside. And so if you have this external pressure on there, eventually our systems are going to habituate and we stop feeling the sensation of urgency. Now, the problem with the rectum is that as that continues, our colon is fantastic. It works really, really hard for our bodies to make sure that we stay hydrated. And it's not really concerned about what the stool is doing. And so the longer it stays in there, it gets harder and harder and harder and harder. And it also gets larger. So there's a Bristol stool chart that actually looks at different types of stool. And I print these off and I give them to every single one of my clients that I work with for incontinence, because it's a very good way to understand what is going on inside your body is actually by looking at your own stool. And there's 7 types of stool that it describes. And the number 4 is what's considered to be typical. And it's long, it's well formed. There aren't cracks in it. It's moist. It's easy to push out or to excrete. If we go to a 3 or 2 or 1, what we're really describing is less and less water. And so it begins to look more like they describe everything related to food, which is just fantastic and really gross, but they get over that pretty quickly. So like a corn cob, and it begins to have cracks in it like a corn cob would. Or I think about think about like, you know, a riverbed when the water recedes and the clay begins to crack up because the moisture is gone. And that's exactly what our stool is doing. And so it cracks up, but it also is accumulating more stool. So it's getting bigger and broader. Number two is even bigger chunks like grapes. I mean, they're really clumped together and really dry. And then a number one would be even just like little rabbit pellets. If you go to the bathroom and all you're getting is rabbit pellets or ribbons, that's significant constipation and significant dehydration of the stool and the rectum, which is problematic. Going the other way from 4, remember 4 is where we want to be. 5 would be an excess of water. And so still well formed, but as it's excreted, it's breaking up and there's loose edges. 6 would be like an oatmeal, and 7 would be the classic diarrhea that our system's like, we need to get rid of something. So we're going to conserve water and just flush everything out, which of course is also unhealthy, and it's going to have challenges for the anal sphincter muscle to actually even contain that, which is why accidents will happen when there's diarrhea as well. But most of the kids coming in for incontinence problems are going to actually be in that 3-2-1 category, with hardened stool that's stretching out the rectum, becoming bigger. And then you have additional concerns that as they're going to the bathroom or trying to go to the bathroom or feel like, oh man, I'm really uncomfortable, I need to go to the bathroom, it hurts, it's painful. They have to strain to try to get out. And so then you're having damage to the anal sphincter, you're having incidents of hemorrhoids, other concerns, and fear or avoidance of toileting happens because it's hard, because it's challenging, because it's painful, which then propagates the problem even more. There are over-the-counter type of laxatives that you can take. I always reference my clients back to their doctor. Make sure that you talk to your doctor. Here's some options of things to bring up with your doctor. I'm not telling you what to do. This is for your doctor. Miralax is a really common one that our pediatricians around here will use. It actually reverses the osmotic process in the body so that we're putting water back into the colon to soften the stool from the outside in. Of course, they could also use Senna or X-Lax, as it's called, to work from the inside. And you can talk about different types of fiber to either bulk up the stool or push the stool. But with any of those, if you're not talking about the effect of putting water into your body, it's going to be problematic. Miralax is stealing water from the body to put back into the colon. Then what happens to your body? You're becoming dehydrated. You're going to have some other problems. And so all of my clients, I'm always telling, you need to drink more water. You need to drink more water. I've had several clients that come to me and say, well, what about water toxicity? That's the thing. And we're worried about water toxicity. And I have them do a bowel and bladder diary. I have them track 2 different days during the week, a weekday and a weekend, and say, well, tell me, here's a piece of paper with a chart that's 24 hours long. Tell me what you're drinking. What are you eating? How much? When do you go to the bathroom? What does it look like? And they bring those back and they say, oh, we drink lots and lots of water, lots of water. You drink maybe 1 water bottle's worth for the entire day. That's not a lot of water. And as they're able to track it, they become aware of, oh, yeah, I thought that we were drinking water, but we really aren't. And so that explains the stool being hardened. And of course, there's other factors that could be playing into that. Diet really does play a large factor into that. Any of your dairy products, milk, cheese, ice cream. I tell people, milk is a fantastic thing. It's got lots of vitamins. It's got lots of good benefits for the body. But if we're thinking about incontinence and we're thinking about constipation, it's not a liquid. It is a mucus, which just sounds, I want a nice cold glass of mucus in my hand right now, because it gets into the colon and it'll clog things up. Cheese does the same thing. It's cottage cheese, any of that dairy, it's going to clog up the colon, unless you balance it with water or other dietary things. So we've talked about the different types of stool. We've talked about that desensitization is going to cause increased problematic physiologic and also behavioral consequences from incontinence. And we've talked about how that has an effect on the bladder. Let me mention a couple more things. So you have this pressure on the bladder. The bladder isn't able to fill as much. But sometimes you actually have the bladder, and you can, if you do a scan, you'll see this. Otherwise, they describe it as, well, this is a possibility that might be happening until we can actually get a scan of it. You can have the bladder fold. And so the child will go to the bathroom and they say, well, I made it to the bathroom. And then 5 minutes later, I had this other accident, this secondary incontinence that happened, but I made it to the bathroom. Why am I peeing 5 minutes afterwards? And it's that there's been some sort of a fold or pocket formed in the bladder that you release. The hard stool is still there. And then after you release, you stand up and you move it around and things shift. And then this extra amount of liquid then comes down. And your pelvic floor is still loose. It hasn't tightened back up and the detrusor muscle is relaxed. And now we have this liquid that just goes out. And there is no sense of urgency. And oftentimes, because of chronic constipation, there's desensitization of the pelvic floor. And these kids don't even realize that they've had an accident. They have no idea. And so that's a lot of times where that secondary incontinence will come from is because of that extra pressure on the bladder, all coming from hardened stool. Okay. Any questions or comments at this point? Makeesa, is there anything that you want to add?
Just that so far in my week or two of treating this, I mean, constipation's been the #1 topic, as well as water intake and tracking toilet habits. So
yeah. So Makeesa is fantastic. Like I said, I've been doing this for 8 years and my caseload is always growing and there's always a need. But I struggle with it because I have other specialties and I have other areas of interest and I want to be able to treat a wide variety. I don't want to focus all on incontinence, but there's such a big need that I said, I need help, and Makeesa has been fantastic. And so she stepped in and has taken some continued ed. So she's helping out and it's really wonderful. But she's just a couple weeks in right now. Okay, so things that we can do besides looking at diet. There are massage techniques that you can actually go with the abdomen. I don't know how far I want to jump into that, but there's a couple levels of training that you can go through. Level 1 will teach just some basic light massage. That's also taught in infant massage to help the gut move. If anybody knows what the I love you massage is, yeah, okay, Karen. That same technique you can use on adults. There's a more specific, I don't know if I want to say invasive, but another skill set of actually feeling along and you can feel through the abdominal wall and actually trace the colon through the abdominal wall and actually feel blocks of stool and being able to massage those. Which, again, I never thought that as an occupational therapist, I'd be massaging somebody's stool through their abdomen, but here I am. And actually allowing it to break up and I'll have kids that haven't been able to go to the bathroom in days. And as soon as therapy's done, sometimes right after the session, it's like, I need to go to the bathroom right now. And they'll have a large bowel movement, or sometimes when they go home, a lot of times when they go home, it takes a little bit for it to still process. But the parents are really shocked. Wow, like every time that she comes into therapy, when she goes home, she has the biggest bowel movement that she has had all week long. And then it slowly builds up until we're able to see you again. And then she has another, it really makes a big difference. Another thing that we can look at is posture and what we consider as toileting posture. Here's our toilet. And this is a good, I guess, less specific, less training intense ways that you can make a difference for kids and adults that are having incontinence is through education. Educating on water, educating on diet, educating on just the basic function of the body. As people understand that, a lot of people understand this. As they understand that, they go, oh, that's why I need to drink water. Okay, I'll be more aware of that. And it makes a huge difference. It makes a huge difference in their compliance as well. But this is another area that we can make a big difference without really having to do much hands-on stuff, not much skilled therapy other than educating and helping them understand. There was a couple years ago, Squatty Potty came out with those funny videos with the pooping unicorn that had the ice cream. Who remembers those? Lisa, come on. Okay. Anyways, it showed this unicorn. It was on this conveyor belt that says, this is where your ice cream comes up from. And it's this unicorn that's pooping out ice cream. And it was a commercial for the Squatty Potty, which is just a product, but the only thing special about the Squatty Potty is that it's a stool that has a cutout so it slips underneath the toilet. That's all it is. Otherwise, I tell my clients, it's like, you just get a stool. If you are sitting on, I need to erase my 80%. If you're here sitting on the toilet, okay, and here's your legs, whoop, 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 okay, and your feet are not touching the ground, that's actually creating a change in the angle of your hips to your legs. And it's going to be at 90 degrees, so it's going to be at a larger degree than 90 degrees because your legs are relaxed and hanging over the edge of the toilet. So then your feet are dangling. Well, what that does on the inside of your body that people don't realize because we aren't transparent is that there's muscles down here that are actually going to tighten around the rectum and squeeze it shut and help hold it shut. That's why it's difficult for us to, don't raise your hand, Lisa. Don't raise your hand. Has anybody tried to poop while they're standing up? Like, it's really hard to do because you have all these muscles. See, Lisa, I knew it. No. Because these muscles are actually constricting and helping to contain the rectum. And so as you are relaxed on the toilet and you're not supported underneath, you've actually constricted around the colon so that the stool is actually harder to pass. And so that's the big Squatty Potty thing, is that they said, well, if you get into a squatting position, which is still very common in other parts of the world, but not in America because of how we build our toilets, squatting does a great deal for us. It actually puts us into a position where it elongates the colon and straightens it out, and the stool actually flows out much easier. And you excrete more stool so that there's less to be built up. It's still having water drawn out of it and causing potential problems as it's carried on. The other thing to consider is how you're sitting up. You know, is somebody on the stool and they're like really slumped forward with super bad posture, almost like folded in half. Some kids will do that, and that's going to do the same thing. You're still messing with that angle. And so having an upright posture, slightly leaned forward, is going to be the best position to be in, feet supported. And then consider what the arms are doing, because our whole body is connected and we're affecting every part of ourselves. This is much more of a, well, you can think of it as a concern for small children. You could also think of it as a concern for adults whose ability to be stable in their posture has been impaired for some reason. Pardon my drinking, lots of talking. As you brace, that's creating tension throughout the torso, and then you're also tensing and essentially causing the same effect, that you're tightening things up so that you don't have that ability to pass stool. So what do you do? For kids or for shorter adults, number one, make sure that they understand how to sit on the toilet. Having a stool that's going to make sure that their hips are at 90 degrees or the knees are a little bit elevated so that they have the best posture available. And then there's also toilet inserts that can decrease the size of the opening of the toilet. There's some really cool ones, and Makeesa, if you remember the name of them, chime in. There's one where it actually is a lid that fits inside the lid of the toilet, and there's a magnet. So you open up the lid and then you can pull down this insert. So it's a smaller hole. So the kid doesn't like, I'm scared to sit on the toilet because I'm going to fall in because my little bottom's not big enough to actually catch on the edges of the seat. And so then they're bracing because otherwise they're going to go in, or they're screwed all the way up to the edge, or they're doing all these other, sometimes I'll have kids that sit backwards on toilets. And it's for that same reason. I need to feel secure, but then they're tensing up their body and they're not passing stool in the most effective way. And then they're causing problems. And so you have that smaller insert and it solves problems. There's other ones that you can sit on there.
So the brand is called Topsy, and it's called a Tiny Heiny Potty. And they're on Amazon for $38.
Yeah, not bad. And there's other brands. That's just one of them, but I actually got one for one of my kids when she was younger, and trying to help her because she ended up with some of this stuff too. And they're nice. They're nice because that smaller seat just folds right up. And so if you have an adult that goes into the bathroom to use it, they just lift it up and they don't need to worry about anything. It doesn't change anything. A lot of people get inconvenienced with the seats that's set on, then you have to take them off. And then where do you put this seat while you go to the bathroom? Like, is there, depending on the size of the bathroom, maybe there isn't even a spot to set it down, but this one there is. And so it's convenient and it saves space and it becomes more functional for a lot of people. Okay, so before we talk about nighttime incontinence, let's talk about some treatment of bowel incontinence and urinary continence during the day. But are there any other questions or comments before I keep diving in?
I have questions.
Okay.
Okay. So I haven't delved into this area very much, and I'm laughing because I remember when you couldn't even like talk about sex or anything in class.
Right?
So
I know. Yeah.
loving it. But
I've come a long ways.
Yes, you have. Okay. So tell me, is there any kind of like sensory component with this? Are you going to talk about that? I'm wondering about, I don't know, like the fear of things leaving your body, different things like that. Are you going to touch on those things?
Yeah. Let me touch on that right now, actually.
Okay.
That does play a role. Sensory-wise, you're looking at. We could take a look at that in a couple different aspects. Number one, let's go where you went. So we're talking about this fear of losing your part of your body or things leaving your body and not really understanding what that is, and so then you become fearful, and so then you're retaining stool, so then you have constipation as a secondary output of this processing issue, and so you address the constipation, but you still have this cognitive processing or subcognitive processing of like, I am fearful to use the toilet. And so then you're looking at, well, what are ways to help them understand and desensitize. One of the ideas that I have, I think that I've done it one time and then I forgot about it years and years ago, because I don't get this challenge too often, is that they'll still go in their diaper. They think that the diaper is fine because they've always gone in their diaper, but once the diaper's off, like everything stops up, and they're just like, no, I can't go. You put the diaper on, in 5 minutes, they filled up their diaper. So they'll sit them on the toilet, but you cut a hole in the diaper so that they feel the pressure of the diaper, but then they go through the diaper into the toilet, and then you can say, oh, look, you know what? Yeah, that rather than going into your diaper, went into the toilet. That's fantastic. We're going to try that again, and just give them that same sensation that they've had where they've felt safe and secure, being able to toilet in a diaper, and then being able to move past that and slowly desensitize them from that experience. You can also, you can remove the toilet completely and use a use a bucket, use a bowl, use a hole in the ground. Other cultures they have different techniques. You go visit other cultures and there's a hole in the ground, and that's where you go into the restroom. That's where you toilet. Yeah. So that's the one side of it. The second side of it is actually looking at the discriminative side of sensory processing, understanding actually where your body is and how your body connects, and the sensation of pressure and movement within your body. And so I see a lot of kids that have challenges with this. If you have low tone, you have low tone throughout your body. And so part of that might actually be affecting the peristalsis of the gut and being able to move stool. And so a lot of times that abdominal massage is going to help them actually move it where it could not be moved before, or not moved effectively. You will have, sorry, I'm losing my train of thought just a little bit. Oh, low body awareness. So low tone, low body awareness. One of my kiddos in particular that I've worked with, she was diagnosed with ADHD, and ADD. She did not have the hyperactivity component, but ADD, and she just had low overall awareness. And so she was seeking additional input, but as far as her body went, she had very poor awareness of how she was moving her body, and she's always just kind of slumped down, and would try to get her moving, and it was just always clumsy and uncoordinated. And so, of course, one of the problems that we were addressing was that she would wet herself all the time, every day, and she smelled like it, and she was always trying to cover herself up with a sweater wrapped around her waist, and she was in middle school, and it was embarrassing, and it was tragic for her emotionally and socially. And so looking beyond just, okay, so are we treating incontinence or are we treating body awareness? Well, we need to make sure that we're treating all of it. And so when you have those kids that, okay, well, sure, we're looking at bowel function, but how is their body doing? And what is their discriminatory, I cannot say that word today, discriminatory ability to understand their body. And so you augment that and you train that, and that becomes more intact and integrated, and then you're also able to treat the bowel, and function goes up. That help? Cool. Okay.
Thank you.
Okay. Other things that you can do. There are some manual techniques for teaching muscle function. Sometimes if you've had pressure down on the pelvic floor for long enough, those muscles also become desensitized. And thinking about body awareness, they no longer know how to use their pelvic floor muscles. And we think to ourselves, it's like, what does that even mean to not use our pelvic floor muscles? It's so natural for those of us who are functional in it that we don't consider the inability to perceive or isolate down at the pelvic floor where you need to. You have this inverse response of, let's talk about the bladder for a little bit. The detrusor muscle sits above the pelvic floor, that surrounds the bladder. And when the bladder is relaxed, the detrusor is relaxed, we're filling up the bladder, but that pelvic floor is tight and it needs to stay tight. And then when we feel that urgency, that pressure of I'm full, so I'm sending up a signal to the brain that says you need to get to the bathroom, or maybe it's before that, you need to get to the bathroom soon. We start to feel that, wow, you know, things are in a state where I need to start planning my trip to the bathroom. Okay, so as you go to the bathroom, we inherently relax the pelvic floor, and then the detrusor muscle contracts so that urine is voided. And then when we're done, the pelvic floor tightens up and the detrusor muscle then relaxes. If this tightens, pelvic floor should relax. Tighten, detrusor should relax. And it's that inverse relationship to each other. Well, if the child has poor awareness, or if the adult has poor awareness of their pelvic floor and they don't know how to isolate it, the most common compensation that I see is that people either tighten their legs or they tighten their abdomens, or both, when they're trying to control the pelvic floor. So think about the potty dance. Everything's tight. Or another really classic one is the kid who will kneel and stick their heel up into their pelvic floor. And you're thinking, that's kind of a funny position. And they're actually applying pressure, trying to stop that. And they may be aware of what they're doing. They may not be aware of what they're doing. But again, it's a technique that they've learned to try to be successful. But of course, it's not functional, and it's not going to be successful in the long run. So we begin to you can actually look for anal sphincter function. You can take like a cotton swab, or sometimes I'll just fold up a tissue and you just brush it along and actually see if you have, it's called an anal wink. It's an involuntary contraction of the anal sphincter. I just did a new eval on a kiddo this last Friday, and who will just have accidents just randomly throughout the day. And so I said, okay, well, let's take a look at this and let's educate on that. And they said, okay, well, let's take a look at the anal sphincter. And there was no response. And the kid did not even feel that I had that tissue down there, which you'd think, wait a minute, that's a really sensitive part of the body. I would be through the roof if somebody did that to me, like, whoa, what's going on down there? And no response. So then I'm looking at more intense ways of treating that through biofeedback. And so you're having a computer that you're hooking up electrodes to the child's pelvic floor. We use electrodes on either side of the anus, and all it is reading muscle movement and muscle electricity. And so then they can see on the screen, and as they contract, they can see the graph go up, or whatever graphic you put on there. And as they relax, the graph goes down, and you can time it. You can do all sorts of stuff with some of the programs that they have, so that they have an actual visual idea of what their muscles are doing. But in the meantime, keeping in mind that they use their legs or they use their abdomens as a compensatory muscle to try to make up for the fact that they don't have control over their pelvic floor. So then you give them feedback. I have the kid lying down and I can feel their abdomen and say, oh, no, you know what? Yeah, it went up, but that was your stomach. Did you feel your stomach? Yeah, it was right here under my hand. Or, oh, that was your legs, because your legs are in my lap while we're doing this. And I can feel that. Did you feel yourself press into me? And they slowly begin to recognize their own body movements. And then we have that one golden time where it says, whoa, hey, I didn't feel your body move at all, and yet that graph went up. Did you feel how that felt? Yeah, that's your pelvic floor. That's what we're looking for. And then they become more and more successful. And as that awareness goes up, that's another key into helping them being able to, when they get to the bathroom, that they say, okay, wait a minute. Or when they need to go to the bathroom, when they feel urgency, that they're able to keep that pelvic floor tight. Going on the toilet, oh, that's the muscle that needs to relax. I know where that muscle is now. Another example is to think about, if you think about somebody who's had a stroke or something else has affected their ability to move their arm, and by themselves they're compensating or they're neglecting that limb, and through therapy they become aware of it, and they've been doing all sorts of other movements to try to get that arm to move or position. But then there's that one time when you have a connection and awareness of that connection, and they get independent movement where it hadn't been there, and the light goes on, and then they're able to isolate, and they're able to go and do that movement again and again and again, and those connections become stronger and stronger. And that's the same thing that we're going to be doing with the pelvic floor through neurofeedback. Lisa, what's your next question?
Gosh, I don't know. No, it's really timely. I just got a referral for somebody who, they've tried everything. They've gone to doctors and chiropractors and anything they could think of, and now they're coming to OT, and this is definitely a new area for me. So this is very exciting.
Yeah.
So I guess I am kind of thinking though, because this is not an area I'm going to specialize in, right? I'm not going to go do a lot of training or anything. But what do you suggest for somebody who's just like a generalist and has a patient with this stuff?
I would get back to those basics. I would teach about the body. But make sure that they understand, well, this is how your body functions, because this truly is an area where people miss out. I'll ask, and even the parents, you know, they say, okay, mouth, yeah, chews up the food, goes down the throat. A lot of times they'll skip the throat. Oh, it goes from the mouth to the stomach. They say, no, it doesn't. Oh yeah, it goes through the throat, and really break it down. Make them do the steps. Because that's what they've been doing before, is they skip the steps and think mouth, stomach, poop, and just like, nope. Okay, we need to talk about the steps. Where does it go after the stomach? And what happens in the small intestine? And why do we have small intestines? Where does it go after the small intestines? Okay, large intestine, here we go. And what happens in the large intestine? And why do we have a large intestine? And then the rectum is at the end, and that's that holding container. And we have muscles down here that help control that. Well, where does pee come from? Because we didn't talk about pee at all here. So where does that come from? Oh, okay, we need to go back to this water. We need to talk about that it goes all over our body, that we filter through our kidneys, that it goes down through our ureters into our bladder, that there's a tube, there's a urethra that exits our body so that we can void in the toilet successfully. How does that all function? Well, we need to look at food and diet. So this, I would say, is a really big key. The second big key is to look at, we need to talk about positioning, and we need to talk about how the function of the body then fits into the function of excreting and voiding. Those two things are key. And then if there's additional complications, then you're looking at, okay, who else can we send them to, or who can I call or send an email and say, Ivan, I need help because we've done this and they're successful, but I need something extra for this one. Yeah. If you could hear my peacocks, that's them saying, yeah, I agree. That's what they were saying. Yeah.
Can I chime in for just a second here?
Yeah.
So I just saw a patient, and I went through this exact, pretty close diagram of where our food goes. And this patient has had incontinence issues for 10 years, really aggressive, invasive procedures, and lots of, you know, colonoscopies and things like that. And we reviewed this, and he could not tell me the pathway of food. I mean, we were skipping parts. We were, oh, that's where poop comes from. No, we got to go back. And so even though like they've been on this incontinence journey for 10 years, he still did not know by himself, without mom chiming in, what was actually happening in his body. So I think it's really important, like, that knowledge of what's going on, because I mean, I didn't really understand all of this as much as I do now, of how everything's all connected. So I think just providing that education is the biggest key, because once they understand what's going on, it's a lot easier to get the buy-in of why they need to drink water, why they need to, you know, keep track of what they're eating and make sure that they're, you know, following whatever advice and home exercise stuff that you give them, because they understand what's going on in their body. So it's always good to review.
All right, so I want to switch, because another big area that we keep running into is nighttime incontinence. Hey, my kid still wets the bed. What's going on? Every single time that I get somebody talking about nighttime wetting, I say, hold the phone. What's going on during the day? Because you cannot address nighttime incontinence until you have addressed if there's any concerns during the day. You will not have success at night if there's daytime concerns. And sometimes that includes constipation that the child and the parent are unaware of, but it's still having an effect on the bladder. And most of the time it's because you're restricting the function of the bladder through hardened stool. So they might still be continent during the day, but they don't have the room to make it through the night with a full bladder. So here's a common thing that I show kids. So this is a conveyor belt, and we're going this way on the conveyor belt. And here I have these boxes with this side up arrow, you know, coming from Amazon. And as things come out of the Amazon, or if you put an order into the Amazon factory, they're going to put it in a box. That box is going to get on a conveyor belt, It's going to go along the conveyor belt, and it's going to end up in the truck. And once you put in that order, there is no going back. You cannot stop that order. It is going to get into the truck. And that's how our bodies work. If we put water into our bodies, if we put food into our bodies, it's now on a conveyor belt, and it's not going to be done until it's in the truck or has left our body in some way or form, okay? So now we talk about nighttime incontinence. We have a signal from our brain that goes down to the kidneys, and there's a chemical that is released that controls the rate at which the kidneys cycle water. We can influence that signal by drinking a lot of water all at the same time, or to flood our body, and then it's going to increase the speed of filtration, and then we're going to have to go to the bathroom much sooner. We can change that through the type of drinks that we use. If we use really sugary drinks, sugar is going to jump through the small intestine, actually skip the step to the large intestine, flooding the body with water. It's going to have that same effect. So during the day, it's really common to void every hour and a half, 2 hours. If we're drinking water as we should, that's a normal occurrence. So how in the world do we go 8 hours during the night without waking up to empty our bladders if we get really full after 2 hours during the day? Well, that signal changes when we're asleep to allow our kidneys to slow down and actually decrease how quickly we're filtering the water, filtering the blood in our body, so that our bladder fills up much more slowly. However, what have you put on the truck or put onto the box, into the conveyor belt? Here we have, this is bedtime. This is wake time, okay? This is our bladder throughout the night. And what we would expect and what we want is that we start the night with an empty bladder. It starts to fill up so that right before we wake up, we have a full bladder. And then, unless you're really weird, the first thing that you do when you get up in the morning is, Lisa, what is it?
First thing in the morning?
First thing in the morning.
Yeah, I get up and go to the bathroom.
Get up and go to the bathroom, okay? Because that bladder has been slowly filling up all night long over how many ever hours of sleep that you happen to get that night, okay? One of the biggest culprits of nighttime wetting, outside of constipation, is that you have dinner here off the screen, okay? And then they continue to be drinking fluids. Maybe they don't drink a lot of fluids during the day. And so then you have, like, if you're tracking a graph of their fluid intakes, it's like low, bedtime, woo! And suddenly you have tons of water intake. Oh my gosh, you're choosing that time to put all the boxes onto the conveyor belt? Well, what's our body supposed to do? You flooded the body with water. It has to go somewhere. And so even though you have fallen asleep, our kidneys are still going to function at a higher rate because we flooded the system, and it has to go somewhere. So then that bladder fills up much sooner, and it can only do so much. And so then you're going to have an accident, or maybe you have an accident sooner in the night. And the most common times to have an accident are either right after they go to bed, they haven't voided their bladder, or they did try, or they did void, but they flooded their body with water. So then you have an accident, or it's right before they wake up. Also very commonly from either flooding the body, or that they're just trying to sleep too long. Sometimes I do have kids that sleep excessively, and when you say, well, wake them up a half an hour early, and then the problem goes away. Sometimes it's as simple as that. But educating them on what to do with a bedtime routine to make sure that they aren't flooding their body with water. To get the proper water into your body, you want a more or less constant supply throughout the day. The challenge is that they'll drink in the morning, they go to school, and they don't drink when they're at school. They come home, they drink some, then they don't drink, and then dinner, and then bedtime. And then we're having accidents. I haven't met a teacher yet anymore who doesn't allow water bottles in the classroom. I think that'd be really weird if you had a teacher who didn't, and if that was the case, then I think that there's some education to be done and some letters to be written. But another thing that that you can look at is, okay, so we've taken care of that. We've taken care of the bedtime routine. The last thing that the child is doing before bed is that they are voiding. We have decreased water after dinner time. I often use that as the benchmark. Okay, you're not going to die if you don't drink water after dinner. You do need to drink a lot during the day. And then after dinner, if you're thirsty, all I'm going to let you until we have this solved is I'm going to let you have just a small drink of water. Just get your mouth wet. Okay. And then you're going to go into nighttime. You're going to void right before you go to bed. That does not count going to bed and then staying up an hour reading a book. I want you to go to the bathroom after that happens. And then we're going to go to sleep. And then I'm going to have the parents get up during the night and say, okay, well, let's start with when do you think that they are having an accident? You know, I think I don't know, it's probably in the middle of the night somewhere. All right, then you are going to get up in the middle of the night somewhere. Let's pick 2 o'clock. All right, so they get up at 2 o'clock and they fill the kid's bed or they fill the kid's diaper. If it is warm, that's really good. It takes about a half an hour at room temperature for fluid from the body to become neutral or cold, to feel cold. And so urine will become cold feeling after 30 minutes. So if it's warm, awesome. The next night, you're going to wake up at 1:30 and see, are they dry or are they wet? If they're dry, fantastic. We know that at 2 o'clock they were wet. We know at 1:30 they're dry. As long as all other things are relatively the same, the bladder is trained already, but to be doing something that we don't want it to do. So we're going to expect that most of the time they're having an accident at 2 o'clock. If it's cold, then we say, okay, we need to go farther ahead. Maybe we need to wake up at 1. Maybe we need to wake up at 12:30. Well, their bedtime is like at 10. All right, well, maybe we need to go back and maybe it's at 10:30, you know, and usually, but that's usually a water intake problem. Maybe it's not until, maybe it's dry, and it's not until 5 o'clock in the morning. Okay, so you're going to be waking up at 4:30 or 4:45 if we can do that and be consistent. And we're going to get the child up, and the child is going to walk themselves to the bathroom. The child is going to sit on the toilet and void, and then the child can go back to bed to sleep whatever extra length there is. If you can do that within 20 minutes, is what the recent research that I've looked at, you do not significantly impair their sleep cycles. 20 minutes. So once you can go a week with the bladder being trained through that method, then you can start to gradually change those increments of time. Say that they're waking up at 4:45. We do that for a week. Now we're going to wake up at 4:50. We do that for a week. Now we wake up at 4:55. Oh, they had an accident on Friday night. Okay, that's fine. We're going to do, where we're at 4:55. We're going to do that for another week. And now we're at 5 o'clock. And now we're at, and usually, you know, I mentioned Dawn Sandalcini. She's really strict at this, and she says, "Oh yeah, you know, you do that at 5-minute increments." I've had success where you start with that, and as they, you know, usually it comes down to, yeah, it was Thursday night and we forgot all about it, and so then the kids slept for another half an hour, but they were still dry, but we got them up and we were successful. Okay, well, maybe that was a fluke, but maybe we're showing more success than we think. So maybe let's jump 10 minutes, or maybe let's jump 15 minutes, and let's keep doing it. And if they're successful, then we go with that, and that's great. But it takes 7 days for the bladder to be trained into a new routine and to show success. Sometimes parents who go like, oh, but that's a lot of waking up in the night, and that's a long, if we start at 3 o'clock and we're going until 5:30 when the kid normally gets up, you know how long is that going to take? I say, yeah, but how long has the child been having accidents? Years. Okay, you know, what is this going to feel like in 6 months? Oh, okay, you know what? Yeah, that is a good perspective. Let me do that. If it's early in the night, it depends on which way the family wants to go. But generally, if it's happening here, you change the time that way and keep this constant. Or if it's here, you change the time that way and keep that time constant. Yeah, and then you train the bladder. So that's also an easy one that you can do in the clinic, and it's easier to pick up for a variety of therapists. Questions?
I find this all very interesting. And honestly, I only was thinking of urinary incontinence.
Yeah.
But there is the other side of things.
Yeah.
So my daughter, I remember when she was like 4, she had been continent, and then we had a little brother, which threw her off and everything. But that child slept so deep that I would get her up at like 10 o'clock at night to take her to the bathroom to try to get her to go so she'd be continent. She was like a stiff board. I couldn't get her on the toilet because she was so sound asleep during that time, but she eventually outgrew it, thank God. So it wasn't a real problem. And that's when pull-ups came around, which were a lifesaver for that. It was like 6 months.
How old was she?
4.
Okay. And 4 is too young for nighttime continence.
Okay.
Yeah, we don't consider that to be a problem until Makeesa, you want to take this one?
That's a good thing to know.
Until age 6.
Hi, Brittany.
Hello, I have been listening, and this has been a fascinating topic. I obviously have zero experience with this, so enlightening.
It's weird to me to experience from 8 years ago being extremely timid about this. 2 years before that, and Lisa referencing that, oh goodness sakes, that here we are in class and I can't even say the word sex. What's going on here? To here I am 8 years later, and it's not only is it comfortable to talk about and comfortable to treat, but it's exciting to see the really significant changes that can occur in the clients and in the clients' families. It's a huge area of need, bigger than I think that probably we all realize. Even me, there are still people that want help, but they don't know where to look for it, and they don't know that something can be done. And when they discover that something can be done, it's really life-changing. It's fantastic.
And this is definitely an area that, like, I don't see PTs or speech therapists encroaching on this area at all.
This actually, yeah, incontinence training is actually dominated by PT because of pelvic floor dysfunction.
Right.
But again, a lot of that, you have a significantly lower amount of therapists who are trained in pediatrics versus women's health, postmenopausal type challenges, which I'm not trained in at all. Yeah.
Do you want to speak at IOTA?
That would be cool.
Okay, I'll get you on the list.
Remind me when it is. It's in October.
October, yeah. They just send out a save the date. There you go.
Yeah, yeah. No, I got that, and I was just like, okay, what's going on?
We're looking for speakers, so I'll put you on my list.
Okay, yeah, that'd be fun.
I just wanted to say too, so the main course that I took was the pediatric incontinence, but I also did some smaller training videos on adult incontinence, especially in the home health realm, because when they're in the hospital, like sometimes there's more significant issues that they're dealing with, and then once they get home, like, oh, well, there's also this, or they'll do the home health eval and see, like, depends, or incontinence supplies. And so in the adult realm, it's still a lot of the same type of education stuff. And then also like tracking the water and the diet, a little bit heavier on the diet, I feel like, and increasing fiber, decreasing fiber. But I mean, still kind of the same, like education on the body and the reasonings why. And then also like one thing they emphasized a bunch is that like, it's not normal to become incontinent as you age. Like that is not like, a lot of times they're like, oh, I'm just old, that's what happens. Like, no, it shouldn't be like that. There are things that you can do to help control that. So like there are, if you want to do it more in the adult realm, there are a lot of really good courses for adult incontinence as well. Kind of similar, but the approach is a little bit different. So anyways, just want to throw that in there.
So I've actually done quite a bit of training in the adult realm and not a lot in the pediatric realm. Kind of like Joanne's maybe hinted at, pediatrics, it seems like it's more bowel is the problem, whereas adult, it's more urinary is the problem. And I agree, it's more diet and pelvic floor strengthening in the adults. Whereas with the kids, yeah, it's more education on how things work and positioning.
This is like the biggest awkward silence ever. This is great.
I was going to say, for the sake of time, we've been going just over an hour, so we can call it good. But thank you so much, Ivan and Makeesa, for sharing this and being willing to talk about this topic. I'm excited about the turnout, and we'll post this on our YouTube page so we can hopefully keep spreading the word. And then, hey, we'll get you a good following at IOTA.
Cool. Hey, thank you very much. This was fun.
Yes. And then I suppose just a reminder, we're going to take a summer vacation and we will be back with Journal Club in September. For all of you loyal fans coming every month, we'll see you in September.